डॉक्टर बगेजा ने कल फुट एंड एंकल पढ़ा दिया है, आज शोल्डर हो जाएगा। बस 2 घंटे 3 घंटे की बात है, सारी ऑर्थोपेडिक्स खत्म।
नहीं, अभी तो 14 दिन का लॉकडाउन और बढ़ गया है भाई।
अभी नी बजी है, रिहान ने नी पढ़ानी है अगले बार।
कब है? हो गया वो फाइनल डेट?
हाँ, नेक्स्ट 9th को।
अच्छा 9 को, बस फिर क्या है, फिर ऑर्थोपेडिक सर्जन बन जाएंगे हम नेक्स्ट सैटरडे।
डिग्री मिलेगी, एमएस किया।
बेटे गवर्नमेंट पहले रिटायर कर रही है 50 साल के बाद ही आजकल, यू नो
है।
हाँ, कह रहे
प्राइवेट में थोड़ा रिटायर करिए।
गवर्नमेंट में जितने 50 साल के ऊपर उनको रिटायर करना है पहले।
नहीं नहीं, डॉक्टर ही नहीं है वैसे। कोरोना के बाद तो डॉक्टर चाहिए होंगे उनको, 70 वाले भी।
एग्री यार।
हाँ,
ये 15 डेज जो लॉकडाउन बढ़ गया है, चीजें तो मुश्किल ही हो गई दिल्ली में यार, बहुत।
नहीं पर लॉकडाउन में बड़ी सारी चीजें अलाउ कर दी हैं उन्होंने। नाउ दे हैव अलाउड लॉट ऑफ एक्टिविटी।
लाइक व्हाट? अल्कोहल अलाउड,
मेड्स अलाउड।
उसमें लिखा हुआ है?
हाँ लिखा हुआ मेड इज अलाउड।
या वो कटिंग भेजना मुझे यार, मेड को वो फोन करना पड़ेगा
टू वर्क। मैं भेजता हूँ डिटेल। हाँ
हाँ, वो जरूरी है, वो भेज दो यार एक बार।
व्हाट्सएप पे फॉरवर्ड करता हूँ।
प्लीज।
डॉक्टर मनोजा, गुड मॉर्निंग।
गुड मॉर्निंग सर। ਤੁਸੀਂ मॉर्निंग करती है सवेरे
एनर्जी ड्रिंक पी रहे हो?
पानी है सर।
अच्छा।
डॉक्टर रमेश, मेरा नेट सही चल रहे हैं?
हाँ सर।
कोई आवाज तो नहीं गड़बड़ गुड़बड़ कुछ हो रही?
नहीं सर, बुलंद आवाज, बुलंद आवाज है आपकी।
ठीक है, वो तो हमेशा सही है
सर। डॉक्टर मनोचा की आवाज नॉर्मल से बेटर आ रही है।
ये थैंक्स टू मनिंदर, उसने सबकी आवाज बढ़िया कर दी है ना?
यस।
मनिंदर ने अमिताभ बच्चन फिल्टर लगा रखा लगता है।
नहीं, वो तो ऐसा है फिर। हाँ, सिर्फ अमिताभ बच्चन की आवाज आएगी उसमें। हाँ, कुछ भी बोलो।
We are not live as yet.
No, boss, अभी लाइव होने 5-7 मिनट लगेंगे because it will take some time. There was some problem in the telecasting. So we are just changing some link. So I think it will take just another 5 more minutes.
No problem, no problem.
तो हाँ, तो we'll start another 5. अभी तो वैसे भी 2:55 हुए। We can take another 5 minutes. Meanwhile, we can discuss among ourselves, among the EC group.
You can discuss anything else other than orthopedics, okay? We need.
Yeah, we are fed up of orthopedics. नहीं क्या? Ortho. जब देखो.
Talk something else, something notorious, something else, right?
बॉस, उसमें भी कहीं कॉपीराइट ना हो जाए।
नहीं, I mean to say normal talk, yeah, not orthopedics.
यार बगैया साहब, I feel ortho is still better than corona. कोरोना ने दिमाग चाट रखा है, और तो फिर भी मुझे लगता है चल यार कुछ अपनापन महसूस होता है।
समीर, मैं ये कह रहा हूँ कि जब 10 लोग बैठे हैं ना, जैसी सेशन खत्म होगा फिर डिसअपियर हो जाएंगे सब। कोई नॉर्मल सी बात हो जो अच्छी है।
आ जाओ, मैं आपको बहुत बढ़िया पुलाव खिलाता हूँ। 5 मिनट है अभी आपके पास।
आए तो सकते नहीं, ये तो दिक्कत है। सब जेल में बैठे हैं।
मैंने तो कोरोना सीजन की आज पहली सर्जरी कर डाली भाई।
ओह, मुबारक हो।
पूरा
क्या किया?
जंपर सा सूट पहन के।
क्या किया?
बहुत मुंह फोड़ा हम।
अरे वाह सर, छा गए सर, छा गए।
इमरजेंसी थी भाई।
नहीं, आई एग्री सर, काम तो करना ही पड़ेगा सर, धीरे धीरे।
हाँ, काम तो करना पड़ेगा। पीपी पहन के सब धीरे धीरे सब कुछ तो सब कर रहे हैं वैसे। डॉक्टर हनमेश, आर यू डूइंग समथिंग?
आई आल्सो डिड वन सर्जरी, इंटरलॉकिंग टिबिया।
हाँ जी।
अच्छा जी।
नहीं, some 5-7 days बैक।
अच्छा,
पीपी यूज किया था?
हाँ, पीपी के में
किया होगा।
सुसाइड करने नहीं जा रहा था।
आप लोग कोविड के टेस्ट करवाते हो कि नहीं?
उस पर्टिकुलर केस में तो नहीं कराया था मैंने।
अबे इसको क्वारंटाइन करो हरमेश को पहले। ये बिना टेस्ट से घूम रहा है।
पर बाकी जो आए 2-3 उनमें मैंने प्रेस किया है कि कोविड करा के आओ, वो आए नहीं वापस।
लगता है भैया हम लाइव।
हेलो डॉक्टर रिहान। डॉक्टर रिहान, हाउ आर यू?
आई एम फाइन डॉक्टर बगेजा, हाउ आर यू?
मैं ठीक हूँ सर, मुबारक हो सर। हमने सुना आप एम्स जा रहे हैं भोपाल, कांग्रेचुलेशंस।
यार कोई रास्ता दिखा दो जाने का। अभी तो भाई साहब मोदी जी लॉकडाउन ही आते जा।
वो आपकी सेफ्टी के लिए कर रहे हैं। रेहान, कैन यू हियर मी?
रिहान, कैन यू हियर मी? रिहान, 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 कैन यू हियर मी? रिहान, 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 कै Rehan, can you hear me? Hello, Rehan.
Yes.
यार आपके वहाँ से इसमें कुछ नॉइज प्रोड्यूस हो रही है आपके वहाँ से. So just see, there's lot of echo.
I will unmute my this thing, huh?
एक बार अनम्यूट करो अपने आप को. Yeah, I think now it is reduced.
म्यूट कर दिया उन्होंने, रिड्यूस नहीं.
नहीं म्यूट कर दिया पर वो कुछ प्रॉब्लम हो रही है. आई थिंक उनको he has to change
नहीं वही कह रहा हूँ, म्यूट
the.
करने के बाद तो आवाज आएगी नहीं ना.
हाँ कोई डिवाइस चेंज करनी पड़ेगी अपने आप को ना.
बगेजा अनम्यूट करो आपको. मैं एक कर्सर लेकर आ रहा हूँ, ये दिखाई दे रहा है?
yes sir.
ओके डियर, थैंक यू.
Yes. आपने 80 स्लाइड बनाई है डॉक्टर मनोचा. 80 स्लाइड्स यू हैव.
35 मिनट्स थे यार.
हैं?
कोई फोटो है, ज्यादा बोलने के लिए कुछ नहीं होता मेरे पास.
दैट इज वेरी गुड. इफ अगर आपका डायग्राम ज्यादा है या पिक्चोरियल है तो इट्स वेरी गुड.
नहीं, इट इज मोस्टली पिक्टोरियल. आई हैव वेरी लिटिल टू स्पीक एक्चुअली.
तो आपको सुनने के लिए तो बैठे हम.
बट मेरे को देख लो, बस सुनो नहीं. दिखा रहा हूँ, बस देख लो.
रिहान आपका मोबाइल पे है, लैपटॉप पे है डॉक्टर रिहान?
नहीं, I think it is on a laptop now.
तो ये नॉइज किसका आ रहा है आपका? हेडफोन है आपके पास? हेडफोन, ईयरफोन?
बेटे प्लीज.
डॉक्टर विनीत आप सिर्फ वेलकम तो कर दो बाकी लोगों को.
यार एक सेकंड वेलकम कर रहे हैं पर थोड़ा सा मैं लाइव स्ट्रीमिंग कर रहे हैं. एक सेकंड, वी आर जस्ट चेंजिंग द लिंक. आई एम जस्ट सेंडिंग द लिंक टू एवरीवन अगेन.
So there was a problem with the live streaming. It said the previous live stream said that basically we are stopping it because we've detected a copyright issue. So we've made another link and we are so the YouTube stopped that live streaming. I don't know why. That was only when a couple of people had joined and there was no clinical content on there. And they stopped that. So we've had to change the link. I've made another link. It's live and it's going now.
हाँ गुड आफ्टरनून. मैंने तुम्हें लिंक भेजा है अभी दोबारा.
So that link now is live and we can go. We can see that on YouTube.
स्प्रेड कर दो जितने अपने ग्रुप में हैं ना, सब कर दो. काइंडली लिंक जॉइन ऑन
YouTube. हेलो मनिंदर, हम समीर. ये लिंक कहाँ पे मिलेगा हमको? दोबारा से हमें लिंक करना पड़ेगा ना, लॉगिन?
अरे भेज दिया आपके अकाउंट में.
विनीत has already sent to all the groups.
ठीक है.
हमें अब नई मीटिंग में ज्वाइन करनी है.
नहीं आपको नहीं करना बॉस. YouTube वालों बाकियों को ज्वाइन करना. आपको तो इसी भी जूम पे रहना है.
तो विनीत हम भी इस पे रहते हैं, क्या दिक्कत है?
आप इसी पे हो गए बॉस.
ठीक है.
इसी नंबर अप टू 100 नंबर कैन जॉइन हियर. बाकी लोग YouTube पे जाएंगे.
ओके.
यार ये डिस्टरबेंस कहाँ से आ रही है?
अरे आई थिंक रिहान कुछ प्रॉब्लम है यहाँ पे. देखो
यार
रिहान को बस रिहान को वहाँ से देखो.
रिहान को म्यूट कर दो.
Computer is a lot of background noise. As soon as you come online, it's.
कुछ आई थिंक डिवाइस की प्रॉब्लम है रिहान आपको.
उनको म्यूट कर दो ना रिहान को.
हाँ नहीं but he was supposed to moderate today's session.
बात होगी तो.
He was supposed to moderate today's session.
अच्छा.
तो अब आई डोंट नो सडनली उनकी डिवाइस की प्रॉब्लम आ रही है.
डॉक्टर शरद,
anyway,
Good afternoon.
We all are ready.
Hello, Dr. Sharad.
Maninder.
Yes, hello sir. How are you?
I can see you.
Dr. Maninder. हाँ रिहान.
Yes.
हाँ.
Good afternoon, Dr. Sharad.
Good afternoon. How are you?
I'm fine, sir. Thank you.
We were looking forward to your lecture.
Let us see. I'll try to make justice to it.
Dr. Sharad, good afternoon, sir.
Good afternoon. Good afternoon, sir.
Nice to see you.
कैसे हैं?
All well, sir. All well. Thank you.
Great. Somebody is coming upside down. क्या बात हुई? Maninder, can we start?
Sure. The live streaming is already there. We already 10 people on the live stream on the YouTube
Right.
are
I
watching.
think then we should get down to business now.
Yeah,
So,
now I think we can start,
we need-
Maninder boss. Everything is
will you
fine.
read?
Yeah.
Yeah.
Okay.
Yeah. Okay, let us go ahead. On behalf of DOA, I welcome everyone. Dr. Sharad Agrawal, our president, Dr. Hitesh, Dr. Harmesh, and our all EC member. And with special welcome to the Dr. R.K. Manocha, who is today's presenter. And I will be really grateful for Maninder to give all this technical support to our talk. And Rehan will be moderating the session. Once the session is over, all the questions will be asked from the various participants. And participants are requested either to send the question to Dr. Maninder, me on the WhatsApp, or those who are logged in, they can discuss through chat itself. So now I welcome Dr. R.K. Manocha and will request him to start his today's talk on the examination of shoulder. Thank you very much. And kindly keep all other than speaker, everyone should keep himself mute. Thank you very much.
Thank you, Dr. Vineet. Thank you, DOA, for giving me this opportunity. So today's topic is, my slideshow is on. Everybody can see my screen?
Yes, it's already shared.
Yes, we can
And
see.
okay, right then. So today's topic is clinical examination of shoulder. So the first thing about the shoulder is that the shoulder is a joint complex and is not only a single joint. It comprises of 5 basically articulations. Glenohumeral joint, we all know. Then there are acromioclavicular joints, sternoclavicular joint, and then there are 2 articulations which are not truly joints. One is scapulothoracic articulation, and then the suprahumeral or subacromial articulations. Now, the most important message is that the shoulder examination includes all these articulations, and one should make sure to give attention to all these components of the shoulder girdle. So now let me show you how these 5 joints work together for the commonest movement in the shoulder, which we know as the abduction. So here you see that's the external rotation of the greater tuberosity. Then it goes up. This is the movement occurring at the sternoclavicular joint. A 25-degree elevation of the sternoclavicular joint is the movement which allows a movement further above 90 degrees. Now this is how the scapula is moving at the acromioclavicular joint. And then both sternoclavicular and acromioclavicular joint rotate the clavicle to bring the scapula forward to further bring about the abduction to around 180 degrees. So one you should notice that the scapulothoracic motions are integral to the abduction beyond 90 degrees. And the scapulothoracic movement is brought about by sternoclavicular and AC joint, they making the movement. So coming to the clinical examination proper, the common chief complaints are a pain. We will be talking about the pain which is intrinsic to the shoulder only with only a tangential references to an extrinsic causes. We will primarily concerned with the intrinsic causes. And then the second common complaint is instability. And the third, which is another very common complaint, is the restriction of movements, which can be either active movements or the passive movements. Now, starting with the history. I think age is one of the major determinant factor to give you a guidance what might be going wrong with the shoulder. In a second to third decade, the instability is the commonest complaint. Between 4th to 5th decade, the complaints refer to usually the impingement shoulder, frozen shoulder, inflammatory joint diseases. And from 6th decade onward, rotator cuff tears becomes the major source of complaint, along with degenerative joint disease.
शोल्डर क्लास का भेजा दो को मैसेज नहीं.
Now, of course, trauma, that means fracture dislocation, can occur at all ages. Now, the first thing that when you are making listening to these patients or making an examination is where does the patient place the palm. Now the patient can place the palm on the top of the shoulder, on the front of the shoulder, on the lateral side of the shoulder, and this is quite a big indicator to what might be going wrong. Let me show you here on these schematics that the frozen shoulder makes the pain to be felt front, back, and lateral. Whereas the subdeltoid pains are on the lateral side. On the front, the biceps tendon is the usual cause of the pain. Of course, fractures is not included in this pattern. This is so characteristic to the shoulder that there is something called like a palm sign and a finger sign. In fact, the pain of the I'll show you the previous slide again. This AC joint, the pain of the shoulder, which is coming from the AC joint, is so well localized that the AC joint is pointed by the shoulder with a finger, whereas the pains which are inside the shoulder joint are pointed usually by the palm. And of course, if a patient places a palm at the shoulder and the neck junction, then this, of course, is not a shoulder pain. What other points in the history? I told you already. AC joint pain is very well localized pain. And you know, cervical pains will associated with the neck pain and the pain over trapezius, which we showed in the previous case also. And sometime on the medial border of scapula. The neurogenic pains, they should be always associated something going wrong in the hand or wrist also. Subacromial pain and rotator cuff pathologies are always very poorly localized over the lateral shoulder. Night pains are a character of the rotator cuff diseases or the primary or the secondary osteoarthritis of the glenohumeral joint. And the calcific tendonitis happens as a sudden onset excruciating pain. And in shoulder, sometimes only pain is present in certain arc of the movement, which is called a painful arc syndrome. Now, coming to the history of instability. Now, in the instability, we should know the two kind of the main things. The one is called, from the history point of view only, is one is called the Tubbs and the another is called Embry. So there are characteristics. Tubbs is traumatic, unidirectional, Bankart's. In this, the characteristic is a Bankart lesion, and this usually requires surgical treatment. Embry is usually atraumatic. The instability is multidirectional. This often is found bilateral on the both sides. Patients are usually subjected only to rehabilitation. And if ever any surgery is done, this is only an inferior capsular shift. So you need to ask whether the instability is arising after a trauma, or is unidirectional or bidirectional, is unilateral or bilateral, or what kind of the rehabilitation might the patient have undergone. What other points you need to ask is, first dislocation. You must know whether the trauma was significant or not. And the subsequent instability, whether they were true dislocation or subluxation. And the reduction, whether that is happening by the spontaneous or is done by the patient or by some medical care provider. There will be habitual dislocators which can dislocate on their will and can relocate on their will. There are how many of the dislocations that happen? How frequent do they occur? Is there any locking, clicking, catching, clunking in the shoulder, or is there any history of overuse? This let me see why the slide is not moving here. Just I'm trying.
It's okay, not an issue. Take your own time.
It moved, huh? Okay. Now in the history, there are certain relevant past and personal histories also. So like diabetes, sports activity, fitness training, gym training, activity profile. Systemic diseases like rheumatoid arthritis can affect the shoulder, of course. Referral from other sites, everybody knows. I will not be dwelling much on it. A recent immobility and bedridden patient is also may also have pains in the shoulder because of a scapular dyskinesis, because of bad posture or certain deformities that might be developing. And then general physical examination also has some relevance in shoulder examination. You need to examine general laxity. Then relevant regional examination like cervical spine or neurological condition you may always see. Distal neurological status you must always see, and try to find out if the shoulder could be a part of some systemic involvement. Now in local examination, we always know this dictum, see, feel, move. That means you move from inspection to palpation to measurement to movements and to special tests. And that's the sequence in which we will be discussing. So inspection. So understand that there are 5 surfaces in the shoulder to inspect: front, back, from above, from the axilla, and of course laterally. In inspection, the usual things: attitude, asymmetry. Now, asymmetry, we by virtue of our training, we keep on looking at the asymmetry from the other shoulder, but that is even more important from the other side of the same part. But in shoulder, it is even much more important. We will be discussing that point again. Of course, obvious deformities, swelling, skin, you have to see for sinus, scar, prominent veins, and of course, ecchymosis like shown in this case. I hope you can make out what this is, and loss of the contour of the shoulder and an ecchymosis here. This might be due to dislocation, this must be a fracture. Now, the height of the shoulder, that's what is important. So, you have to see the height of the spine of the scapula, the angle of the scapula. These are the two things that you have to mark. And of course, you have to see for muscle atrophies, like in the supraspinatus fossa there and in the infraspinous fossa. It is important to look for the atrophy from the lateral side also, because that is what gives you the best idea how much the atrophy have been might have been occurring, and you need to compare it to the other side. Of course, contours of the shoulder I discussed that they will be commonly lost in shoulder dislocations. Now, there may be some kind of deformities which appear or aggravate on resisted movements, like a winging of the scapula, like in here. So the winging of the scapula, if the serratus anterior weakness has happened, the winging of the scapula. And if you ask the patient to forcefully bend his elbow, you will tend to see this porpoise sign. This is another deformity. Now, palpation, there are some structures which are easily palpable. Of course, clavicle, scapula, acromion, greater tuberosity, lesser tuberosity, and the bicipital groove in between. You can, of course, feel the coracoid process, manubrium sterni, and the sternoclavicular joint. But two other structures you are also able to palpate with some activity of the patient is the medial border of scapula and the inferior angle of scapula. But in all palpation, you must remember this, that you never fail to start with local temperature and tenderness, and that the tenderness includes AC joint and SC joint, and you never fail to end with lymph nodes and distal neurovascular status. Now, coming to palpation, there is a specific method described for the shoulder palpation. Here you see in this picture that the shoulder is actually from the top covered by the acromion as well as the clavicle, and only a small part of the head is uncovered. So it's not easily accessible to the palpation. So for that, there is a Codman method of palpation. What you're supposed to do is to do an hyperextension of the shoulder that will bring the proximal end of the shoulder out from underneath the acromion and the clavicle, and you'll be able to palpate. And this is important part of the palpation because you palpate the rotator cuff insertions by this only. And you actually feel the greater tuberosity's prominence in this. You can sometimes feel even the rent or the sulcus in the rotator cuff. And you can feel the margins of that rent or sulcus. And so much so that if you fail to palpate the margins of a cuff tear and the cuff tear otherwise you suspect, then it also is an indicator that it may be actually a very large cuff. The tenderness without sulcus may indicate actually a calcific deposit. If there is very severe tenderness and you cannot feel for the rotator cuff tear, this may be indicative of calcific deposit. And of course, an abrasion sign. At 90 degrees abduction, you can sometimes elicit the carapatus, which is called as the abrasion sign, and an indicator of a subdeltoid disease. Now, palpating the proximal humerus. Now, again, I told you the palpating the proximal humerus is also possible bimanually. You can feel the head by the Codman method, and the whole of the proximal humerus you can palpate by this bimanual method with your one hand on the outers of the shoulder and another hand in the axilla. This is one of the very important palpation method because this helps you in differentiating intraosseous from an extraosseous swelling. Now, movements. We know what movements are, but let me just enlist them. Abduction, adduction, flexion, extension, internal rotation, external rotation. Of course, they can be active and passive. But here, what is important is that you have to examine the glenohumeral movement separately from the total shoulder movement. I showed you a picture, a movie in the beginning, wherein I showed you that the how shoulder movement is associated with scapular movements also. Then you need to separate the glenohumeral movement from the total shoulder movement, and therefore you need to learn to fix the scapula. Of course, you must remember to comment about ACG, SCG, or scapulothoracic articulation also. In this regard, you must understand that the shoulder is a joint quite different than the other joints in terms of that is the plane of the scapula, which is the pivot for the movement of the shoulder, is not sitting in the same plane as the body, and therefore and then this shoulder joint has an extreme mobility not matched by any other joint, and the description of the movements in this place is quite confusing. Let me try to remove a little bit of this confusion. Now let us this is your plane of the body, this dotted arrow, and that solid arrow is the plane of the scapula, and that plane is angulated around by 30 to 45 degrees to the plane of the body. Now, if one were to consider the actual definition of flexion and abduction, the flexion plane should be this plane to frontal plane, and the abduction plane should be this plane. And then what is this? So this movement is a little bit of both abduction as well as extension. And what is this? This movement is a little bit of both flexion as well as abduction. So that creates a little bit of problem in a shoulder describing the movements. So let us see here. So this is how an extension, flexion, extension you would normally understand. So that is how this would be extension. This is the flexion. So, but if you compare it with another ball and socket joint, that's the only flexion extension you get in the hip. So what is this flexion then? This is hyperflexion. And what is this extension? Then we call it as hyperextension. But then what is this? Here the frontal surfaces are coming close together, and by definition this is flexion. But this is only true flexion. So this is flexion or this is flexion. So this is true flexion, this is true extension. This is the vertical flexion, which we would understand from the glenohumeral joint, which is the flexion extension. So this is vertical flexion and vertical extension. To make this distinction, we describe in shoulder two ways: a horizontal flexion and horizontal extension, and a vertical flexion and a vertical extension. The confusion doesn't end there. Let us see another. Now this is again your abduction. So this is how your abduction, if you were to talk about the hip only, the abduction would be this movement to this movement. So above that is hyperabduction, inside that is hyperadduction. Now let us see this. Now this is also adduction and that is abduction. This is a horizontal flexion also. We saw in the previous picture, this is a horizontal flexion also. And that same thing is in the same plane is also in adduction. So what do we call that? To remove, let this picture will make. So your abduction and extension is starting from this plane to right there. Your flexion extension is starting from this way to this way. So this movement then has to be a combination of the movement of the flexion as well as abduction. So we have started this calling as horizontal abduction or horizontal flexion, and that we call as horizontal abduction or horizontal extension. I hope this point is clear. If you have any question, we can discuss it later. So this 90 degrees abduction adds always another aspect to the movements in the shoulder. So therefore, the internal rotation also needs to be checked. One in the body plane, the internal rotation, and also again at 90 degrees, then this will be in 90 degrees to the body plane again. So how to demonstrate a movement? So unless specified otherwise, demonstrate movements in reference to the plane of the body. But that is what you will do. But the examiner may ask you to demonstrate the movement in the plane of the scapula. We'll discuss what is the importance of the movement in the plane of the scapula when we come to the special tests, because most of the special tests are done in the plane of the scapula. Now understand what is a forward flexion and forward abduction. You must understand what is a horizontal flexion abduction and horizontal extension abduction. And that flexion extension, abduction adduction, they occur with reference to the true plane of scapula. But what you talk in terms of the body plane, that are usually abduction, extension, and flexion, abduction, flexion, and extension, abduction. Sorry. So you must. What my purpose was to explain the rationale behind all these terms which you know. You need to know true flexion and true abduction because most of the tests are done with reference to the plane of scapula. Listen carefully what you have been asked to demonstrate. And if you have not understand, clarify with the examiner what you have been asked. True abduction, adduction, or abduction extension with reference to the plane of the body. Now, internal rotation method regarding the movement demonstration, there are certain methods specific to the shoulder in which we demonstrate this movement. Often examiner asks you to demonstrate internal rotation by thumb hitch method. This is the thumb hitch method. You carry the tip of the thumb to a plane on the spine, and you refer to the level of the spine as the, you can do it one or both hands together. Both hands will be a quick method to compare the two sides of the movement. Now, there is another quick method of demonstrating the movement, which is called a Apples scratch test. You can ask the patient to abduct and extend and touch the other scapula, other side of the scapula. If he's using right hand, he touches the left scapula. And from the underside also, you can touch the lower angle of the scapula. This is a quick this thing. So that way, he's touching here, he's touching there. And of course, quick method for internal rotation and abduction is to touch the opposite shoulder from the front. Now, we were talking about the active and passive abduction. That is very important to understand that there are total as well as glenohumeral movements. So you need to understand how you fix the scapula. That's the commonest method of fixing the scapula. You have one thumb on the spine of the scapula, another fingers are going in front and holding the coracoid process. You held the spine of the scapula and coracoid process together, and you fix the scapula, and then you make the shoulder. Another way is to hold the angle of the scapula, and then you can do the passive abduction. So you need to understand the fixing of the scapula before you start demonstrating the passive movements. Now that's the range. I hope everybody understand what is the abduction range, forward flexion, extension, external rotation, internal rotation. So that's the by thumb hitch method. That is how you will describe internal rotation from T5 to T10. And of course, adduction and horizontal rotation, they are between 50 to 75 degrees. Now, passive range of motion, here I have described everything total as well as the glenohumeral. So flexion is glenohumeral is just 90 degrees and the total is 180 degrees. Extension glenohumeral is just 60 degrees. Abduction is 90 degrees glenohumeral, total is 180 degrees. Horizontal abduction is 20 degrees glenohumeral and combined is 40 degrees. Horizontal abduction is glenohumeral just 15 degrees. External rotation is 60 degrees and internal rotation is 100 degrees. Now, other joints of the skull. Regarding the scapular movement, you basically, I'll be describing how you measurement, this something about the scapular movement in the measurements also. But you provide commenting for the scapular movements at the time of the movements. You need only to tell whether you detected any kind of abnormal movement of the scapula. Like if there's a winging of the lateral border that happens due to medial border that happens due to long thoracic nerve, or a winging of the lateral border that happens due to trapezius weakness, and a scapulothoracic dyskinesis, which may happen even without any weakness of the muscle. And ACJ, SCJ, you just need to comment whether the mobility is comparable to the other side or not. Now, strength testing. Now, rotator cuff muscle strength testing is required routinely. This we have to do. We will discuss that with the special test because that is part of the special test. But one actually needs to test all muscle working at the shoulder, like deltoid, pectoralis muscle, latissimus dorsi, serratus anterior, rhomboids, and trapezius. I have not described how to test them. We may take this at some time. For the sake of the time, I have not described this because I'm restricting myself to the shoulder only. So these are the muscle which act on the shoulder. This is just a list. You can find it in the books as well. So now measurements. So that is how you measure the movements in the shoulder. That's goniometer. Whenever I have gone for some DNB examination, I find it very disappointing that our DNBs often do not understand where this point of the goniometer is to be placed, where one arm, the reference arm, is to be placed, where is the other arm is to be placed, and they even don't understand which angle to measure, whether this open angle or a closed angle. So it is important for you to understand this, that you always measure the closed angle. But in this case, because this is a movement in excess of 90 degrees, you will be measuring actually the open angle. And this is how you will be measuring in a forward flexion or abduction also. Now, in measurements of the movements. This is another, I told you, Apple scratch test. You can actually make both your hand move together to touch the opposite scapula, and then you can measure the distance between your between the two hands, and you can tell the measurement of the movements by the length of this scratch test as well. This is another way to demonstrate external rotation in adduction and in 90 degrees abduction. Now, of course, everybody knows how to measure the wasting. You should always choose the same reference point and possibly the biggest girth. Apparent length in the shoulder is from C7 spinous process to the tip of the radial styloid. And the true length is measured as 2 parts, angle of the acromion to the tip of the lateral condyle, that's how is the true length, and the tip of the lateral condyle to the tip of the radial styloid. Again, the measurement. One of the very common, this you will possibly not get to see in a case, but this you must know, Bryant sign. Thus, the length of the axillary fold, the height of the axillary fold is increased if there is an anterior inferior dislocation. And this is a Calavis test, again found only in dislocation, where you measure actually the girth of the axillary fold. Now, scapular slide measurement. Now you have to, that is scapular slide measurement is you mark the medial border from the of the scapula compared to the central midline of the spine, vertebral midline. So that you are supposed to do at 0 degree abduction, at 45 degree abduction, and a 90 degree abduction, and to make comparison to the other side and make a comment whether they are comparable or not. Now, neuromuscular vascular examination of the upper limb, that's not really the part of this today's thing, but there are very few conditions which are intrinsic to the shoulder, like an axillary nerve. You must know what is the regimental badge area numbness. You must know what happens to the scapular nerve. If the suprascapular nerve is involved, then what happens to your muscles and which muscles are supplied by this, and what happens if the long thoracic nerve, we discussed about the long thoracic nerve in any case. Comes to the special, just give me a break, I'll take water a little bit. So test for instability. Now we'll be taking all the special tests in different parts depending upon the pathologies. We first of all will be describing the test for instability. Now instability can be actual dislocation, which could be acute or neglected, or a chronic instability, which is more likely that you will get an examination as a case. But this is often a very popular test with the examiner, which is a Hamilton ruler test. I've shown you this with a particular clinical situation where it will be actually required and where it will be actually helpful to differentiate. It is a very important test for you to differentiate between a proximal humerus in which the patient will have a pain and a deformity of quite a similar type, a proximal humerus fracture, and a dislocation. In a dislocation, the patient at straight ruler, one is able to touch the acromion as well as the lateral epicondyle. But if the contour of the shoulder is intact and the head of the humerus is sitting within the glenoid cavity, the head of the humerus pushes the ruler out, so that you can either, with this ruler, you can either touch the acromion or you can touch the lateral. So that is a negative ruler test, and that is a positive ruler test. Now this is a Dugas test. This is again, now this is very important. There are 2 parts to a Dugas test. Ask the patient to place his hand on the opposite shoulder and then lower elbow to touch the trunk with the lump. Patient may be able to do one and may not be able to do the other. So you have to explain in those terms. So patient is not able to touch elbow to trunk in dislocation. In fact, if ability to do both parts of a Dugas test effectively rules out dislocation, whether it is anterior or posterior, and confirms that there is a good glenohumeral location. Now coming to the chronic instability. Now you have to understand 3 concepts about when I describe the chronic instability and a testing for. Most of the chronic instability are basically the tests for apprehension. So you have to understand what is a position of vulnerability, what is an augmentation of apprehension test, and what is a relocation in an apprehension test. So the position of vulnerability for an anterior dislocation is abduction and external rotation. For a posterior dislocation is flexion, adduction, and internal rotation. Mind you, this is just not opposite, there is an flexion also. And for inferior dislocation is hyperabduction. Now, augmentation is an exaggerated position of vulnerability or a force in direction of instability. You remember? Force directed towards the position of instability or a position of vulnerability is exaggerated in one or the other way. That is what is called an augmentation. And relocation is when we apply a force in direction opposite to the direction of instability. Now let us see how. Now, this is your apprehension test, the standard apprehension test, which is we do. This is how you do. Patient is lying down on a shoulder with the shoulder is supported on a hard surface. You carry the patient into abduction external rotation, 90 degrees abduction external rotation, and observe whether the patient has a protective spasm sort of a thing or apprehends that it may come out or may have actually a pain. This is an alternative to an apprehension test and is called a fulcrum test. Herein you support the back of the scapula and the shoulder, and this is not truly called an augmentation, but this is the same way to conduct. Sometimes people may ask you, what is a fulcrum test? Actually, it's just providing a fulcrum to the movement, so the patient is not able to compensate for your abduction external rotation by any other movements of the body. Now, what is an augmentation? So here you see an augmentation. This is an augmentation. Patient is just not only in 90 degrees of abduction, he is in some degrees of hyperextension and abduction. You can carry it up also, and then also it will be called as a, augmentation. In this case, the augmentation is also achieved by a force applied from the back. This is an augmentation. The examiner is pushing with his thumb on the back of the shoulder against the head of the, and if apprehension comes in this with this forced anterior push, then it is also called augmented apprehension test. You can do the same test, and Protzman has described this to make your hand of the femur rest on your hip, and you can ask the to push it frontward while supporting it from the front also, where you can feel for some click or clunk also. Now, this needs to be measured also, this test, apprehension test. Rockwood has described that you need to describe the angle of apprehension, because that seems to correlate with what we finally found as the pathology. If an apprehension test is positive at 45 degrees, this is likely to be a bony Bankart. If it is 90 degrees or above, then this is soft tissue Bankart. If the apprehension test happens at 120 degrees or beyond, there's likely to be only a subtle instability. Then you have to correlate it with the history available. Now we'll be talking about relocation test now. This is called job relocation test. You remember, this was the patient in which you applied a posterior push to augment the apprehension. Herein, we create the apprehension, patient gets the apprehension, you carried it into abduction external rotation, when the patient gets an apprehension, and then you push from the front backward. As you push, you try to relocate, and the patient's relief of apprehension. And now you may be able to increase further before the apprehension happens. That is what is relocation test. Now this relocation test is another part where you call as anterior release test. Now you again bring to the place where the patient had an apprehension test, but you keep on pushing, and then you suddenly release the pressure. The patient has a reappearance of apprehension test. Actually, Jobs relocation test is supposed to be a test of both a diagnosis as well as the therapeutic benefit. It is said that the patient who are benefited by job relocation test and as a true anterior release test will be benefited by Bankart repair as well. Now coming to the posterior instability. Now I told you position of vulnerability, that is flexion and internal rotation with adduction. So that is apprehension, you push it. Here you require to actually push much larger because the posteriorly the shoulder is quite well stable, and that's why it is called crank test. You can do a jerk test, and that is what is an augmentation apprehension test. You can actually feel a jump, inflection, when it will be called. This is only in this is only in adduction. Okay, adduction and forward flexion. So when you do an internal rotation also, you can just do a jerk or jump test, which will be present in instability. In this case, you can again patient have, if only as a pain or apprehension, you make a diagnosis of subtle instability. There is a circumduction test described for apprehension, for eliciting apprehension in posterior instability. So what you do in this is, from a position, you take the patient's movement from a position of stability, which is abduction, extension and external rotation, to a position of instability, which is flexion and adduction. The patient from this place, when he has a good feeling, will develop an instability when he comes to this position. This indicates the posterior instability. Now, inferior laxity. Inferior laxity is usually tested by an augmented apprehension test. So you push, you carry, and this is the position of vulnerability. You can carry it higher up also, but there will be difficult to test. So in this position, the augmented hypertension, you do an augmentation. So you push it down, and if the patient develops apprehension, this is called Fegan's maneuver. Maneuver is a way to elicit apprehension and inferior laxity. Now, there are certain other tests also described and variably asked by the examiners also. One is a load and shift test. This is equivalent of the shoulder latchman. You carry the patient to 90 degrees. If there is a apprehensive at 90 degrees, then you're supposed to test at 90 degrees. But this is usually required in patients who do not have an apprehension at 90 degrees, because then you need to test it more. So you carry it 120 degrees or more, wherever the patient is comfortable, and then you can push it from the back like this. This is pushing, and there is a feel for the humeral head subluxation with the thumb in front, and you have to compare this with the other side. This is a way to test subtle instability which are not as yet causing causing apprehension. You can conduct this test also, but this is not augmentation. Herein, you will be only able to test the hyperlaxity created because of the injury of the ligament. Herein, you mind you, this is not an augmented position, so this is a normal position. Again, it is significant only if you compare it with the other side. Now, another, the slap, the test for the slap. The very commonly asked O'Brien active compression test. You have to understand that this is called an active compression test. This is basically is to elicit a biceps pain and a pain inside the shoulder with or without click. So why is this important? So what do you do actually in this? You carry the patient's arm to 90 degrees of forward abduction, and then you carry 10 degrees of further reduction, and then you carry into maximal internal rotation. Ask the patient to forcefully abduct it further, and while you are pushing it against. Now this position pushes the biceps under a great force, and the bicep being attached to the superior labrum pulls upon the superior labrum. The patient will have a pain either of the bicep or inside the shoulder with or without click. So the site pain, important for this positivity is that the site of the pain should be reported by deep inside the shoulder. Now, this test, I'll be telling you something like, which is called cross arm adduction test, because you carry the arm into cross arm. So sometimes you can have a pain on the AC joint with this position only, and that is considered a false positive. When you call it a positive, is that the patient is a pain when it is fully internal rotation. You do the same test in a maximum external rotation. If the patient's pain reduces, then you can be sure that the pain was actually due to the biceps pull on the labral anchor. This must become pain-free because the traction force on the biceps is withdrawn by an external rotation. Now, this another test for again, this is also called a biceps load test, less commonly asked. Of course, you carry the patient to abduction external rotation. Again, the main difference for an apprehension test is that here you are actually asking him to forcibly contract the biceps. So if the patient has apprehension and has a lap also, then the pain and apprehension worsens, and pain and apprehension decreases if the biceps and superior labrum and the biceps anchor are healthy. Decrease is important because now the muscle come into action. If the patient's apprehension decreases, actually this is also a way to detect the stability of the superior anchor. If it decreases, it indicates truly that the superior anchor is normal. In the presence of apprehension, it might have been present due to anterior lesions actually. This can be tested both at the 90 degrees as well as 120 degrees. Now, this is something also labral crank test. Sometimes it may happen that the patient who reports instability has no apprehension in any of the foregoing tests. Then you're supposed to test for the labrum as such. So what you do is you carry it 90 degrees abduction and then you push against the shoulder. This is actually the internal rotate and external rotate against the shoulder. This is done always in the plane of the scapula because that is the best way to compress the labrum against the glenoid. So this is equivalent to the Apple's grinding test, what we do in knee. By this reference, I hope you understand. There you try to compress the meniscus between the two bones, and here you try to compress the labrum between the two bones. So this is, again, you can do this labral crank test, can be repeated in hyperabduction also. This is a situation in which this is an augmentation test for a very subtle instability in which there is in which a patient might not have ever felt the instability, and this in this particular position you should be very sure that the all other tests have been normal, and then only you are supposed to test for this crank test in this hyperabduction. Now, a multidirectional, I told you anterior, posterior, inferior. Patient may have a sometime multidirectional instability, and this is how you test for the sulcus test. The patient sits and then you pull down, and this is the kind of the sulcus appears just below the acromion and between the acromion and the head. Appearance of this sulcus is a test for multidirectional instability. Okay, now we come to the test for the subdeltoid space. Subdeltoid is a place for the impingement. So we will talking about the impingement test. There are mainly two impingement tests. You can read about what is the sensitivity specificity in the book. What your basic principle here is that you're trying to elicit the pain by decreasing the subdeltoid space. And what is the position of vulnerability here is basically is an abduction and an internal rotation. So there are two tests. One uses abduction, internal rotation and abduction. Another uses, this is force abduction, and then you do an internal rotation. And this is flexion, then you do internal rotation. So this is called a knees impingement test. So this is confirmatory. You can do actually a confirmation of an impingement also. That if you place an knees, this is knee impingement sign, and this is knee impingement test. Sorry, that was the reason why I placed both these things. Often you are confused into saying what is the knee impingement sign and what is the knee impingement test. The knee impingement sign is what you do clinical. A knee impingement test is a invasive test in which you inject a local anesthetic in the subdeltoid space and you repeat this test. If it becomes pain-free, this test becomes pain-free, it actually is diagnostic of an impingement causing the pain. This is Hawkins-Kennedy test. Again, an abduction, and you force the internal rotation. You force it, right? This is another. If it important here to remember is that this abduction has to be a scapular plane abduction. I discussed what is a scapular plane, and that is the reason why you must know what is a scapular plane abduction. Now coming to the rotator cuff test. Now, Codman examination system we already said. The Codman drop arm test is the screening test. Why you should not call it a screening test? It's a functional screening test. A person who is has been really worried about his rotator cuffs will have this Codman drop arm test usually positive. Now, what are the principles of rotator cuff testing? Here, it is the strength testing mainly. So that is why I didn't describe the strength tested of rotator cuffs in the muscle testing. So how do you test for the strength of these muscles? We'll come to that now. Now, what is a Codman's drop arm test? I hope everybody of you know, but just for the repetition. So active abduction, scapular elevation included. Now passive abduction, there is some background now. So passive abduction full. So if a patient has there is some sound from back, it is disturbing a little bit. So please mute yourself by whosoever has this sound. So if a patient has a full active abduction, if a patient on asking being active abduction has only a scapular elevation and no true active abduction, but has a passive full abduction, So then you can be thinking of a rotator cuff tear. Now, passive abduction may be painful and restricted in glenohumeral stiffener. So that test is not in glenohumeral stiffener. The prerequisite for this test is that the patient may have a scapular elevation on active abduction, but passive abduction should be passively abduct shoulder to maximum abduction, and then withdraw support and ask the patient to lower the arms slowly. The patient usually loses control between 60 to 120 degree, and the arm drops suddenly. This is actually a test for supra and infra intactness, and the specificity and sensitivity you can all read. You actually are supposed to know these specificity and sensitivity tests. I hope Maninder puts it on the YouTube, this presentation, and then you can read this and memorize this. You are supposed to know that. Now, supraspinals. Here comes the importance of the plane of the scapula. All rotator cuffs are examined in the plane of the scapula. So there you see the plane of the, that's the plane of the body, and that's in front, 15 to 25 degrees. Forward flexion is the plane, or forward abduction. That's the confusion. The forward flexion or abduction, and that's the position in which you test for the supraspinal. This test is very popularly called the Jobs empty can test. Why it is empty can? Because you are actually seems to be emptying a can. That actually refers to your thumb pointing downwards. So that refers to basically internal rotation. This test can test tear, tendonitis, and an impingement. So if it is painful, it can be painful, weakness, or both as well as painful as well as weak. So in a painful test, weakness can be pain inhibition or a muscle tendon help. So if the patient has a pain in this test, in empty canes test, that means a force abduction against the force of the examiner in a plane of the scapula. If there's a pain, the pain could have been because of pain inhibition or a muscle tendon ill health. So how you different? Then you do a full cane test. You do external rotation in the same position. If the pain decreases and but weakness persists, then this is likely due to tear. If the pain decreases, but and muscle weakness also decreases, but that means muscle strength becomes better. So then this is due to tendonitis or impingement. So this test can also be has been also been described in forward flexion when it is called thumbs up or thumbs down sign. So it's exactly the same, but I think more examiners, they depend upon the abduction in the plane of scapula rather than the forward abduction. How you test for infraspinatus and teres minor? Basically, you are testing the external rotation strength. That is the way to test the bilateral external rotation strength. Patient has arms on both his sides, elbows are flexed to 90 degrees. He pushes against the palms of the examiner, and you compare the both sides. I told you already, this test needs to be done in both 90 degrees abduction as well as in adduction, which is 15 degrees. Now, this test also can be repeated in external rotation, there where there is active control. This is a test of an active control. 15 degrees abduction, that's the plane of scapula. So you hold it in external rotation and ask the patient, carry it to external rotation. Examiner passively carries it to external rotation and ask the patient to hold it in that position. If the patient's external rotators are weak, patient will not be able to hold and the external rotation falls in front. Patient goes into some degree of internal rotation. You have to repeat that in 90 degrees abduction also. So there he holds it in maximum external rotation, and as soon as he leaves, the arm comes a little bit further forwards. Actually, there is a lot of a lot of description about the teres minor test. Truly speaking, you may not be able to test for the teres minor isolated. You may actually, in clinical situation, may never be required to test the teres minor and external rotator separate from the internal rotator. But there are certain neurological conditions in which the teres minor can get involved, because teres minor is not supplied by the suprascapular nerve. It is supplied with axillary nerve. So it is a separate nerve supply compared to the infraspinatus. So in a certain cases, when the suprascapular nerve is involved, teres minor may actually escape, or when the suprascapular nerve is good, the infraspinatus may be good, but the teres minor may be lost because of a quadrangular space syndrome. So for that thing, this is called as the hornblower sign, or is called as Partes test. So you ask the patient to place her arm with the elbow fixed to this thing with the clenched fist in front of his mouth in this position. If the patient is able to maintain this indicates both teres minus or infraspinatus power is good. But if he is able to maintain only this position, only in this position, drops to this position after some time, this may not be immediately positive. If you ask him to hold for a minute or two, this slowly will start dropping. So if it drops to this place, this is called teres. This is due to teres minor weakness. But internal rotation is maintained, so his infraspinatus may be good. Now, that was Hornblower's sign. Again, here the confusion of sign and a test, like the impingement sign and the impingement test. So you have to make this distinction. So what is a teres minor test? So teres minor test is that you carry the patient's position into 90 degrees shoulder abduction in the scapular plane and with the elbow flexion. Patient attempts registered external rotation. He pushes against the examiner of the hand. If there is a weakness or there is a pain, you need to compare it to the other side. Then you can say that the teres minor is weak, and that is what is called Hornblower's test. Internal rotation strength, we will be now coming to the subscapularis. Of course, the internal rotation. So again, you test in the same way, the arm at the side, 90 degrees elbow flexion, internal rotation against resistance, and you need to compare with the other side. This is a commonly asked test, but you have to, what is the prerequisite? This is a common question. They ask you to explain what is Gerber's lift-off test, you explain. And then they ask you what is the prerequisite. Prerequisite is that the internal rotation range should be good enough for the patient to carry it on the back. So this test is possible only if the patient has sufficient in internal rotation to carry his arm on the back. So this test is not applicable when the patient has stiffness and has a stiffness of the internal rotation and cannot carry their thumb behind the back. So what you do actually is you ask the patient to lift his palm, his back of the hand off his back, and the examiner pushes it. If he is able to do it, that means the subscapularis may be somewhat intact. Then you push against the arm, against the push of the examiner, and you compare with the other side, and you can detect even the weakness. Subscapularis bear hug test is a very popular test because of its name. Now, what you do actually in bear hug test, you ask the patient to. This is how he is pushing it down onto his upper shoulder, his palm onto opposite shoulder, while the examiner pushes it up. So the patient is pushing it down, red arrow, and the examiner is pushing it up, the blue arrow. So if he is able to do it against the resistance, that means the subscapularis is good. You have to again compare it with the other side. This is Napoleon sign again, the very calm. So this is also called, that was lift off test. This is called belly off test, not to confuse. This is belly off test, that is Gerber lift off test. So the belly off test is you ask the patient to lift his palm from the front of the abdomen. Mind you can conduct this test even when the internal rotation is restricted and the patient not able to carry it on the back. So this is the test which is applicable when the patient does not have full internal rotation. So he pushes against the push of the shoulder and you compare it with the other side. Now, again, belly of test is different. Belly press sign is different. So what the belly press sign is that you ask the patient to press against his belly and keep on holding his shoulder so that he doesn't carry the shoulder back. So he will not be able to press if his infraspinatus or internal rotators are weak. He will not be able to push his belly with the palm, with the elbow kept in front. He will tend to pull it, do it by this method, by using alternative muscle. If he does this, makes the wrist flexed, carries the elbow backward, then that is what is called belly press sign. Now AC joint, there is only one test, cross arm adduction test, but I believe that that is equivalent of the Faber test. Patient carries the arm onto the opposite shoulder and you forcibly further adduct it, and you will have a pain on the acromioclavicular joint. But I have seldom needed this test. Acromioclavicular joint is best diagnosed by the finger sign. Ask the patient to point the source of the pain with one finger. With the AC joint, the patient will be unmistakably going towards their AC joint. Now, there's another biceps. Biceps is mind you, is tendon is an intra-articular structure. So this all passes out of the shoulder within the groove, but this can become unstable in the groove. And these are the tests of testing the stability of the biceps in the groove. So if the biceps is unstable in the groove, the pain may be in the shoulder. So there are two speed test and ergosin test. I think everybody knows them. This is in external rotation in forward flexion, and that's external rotation, resisted external rotation and supination in adduction. खत्म हो गया? अरे नहीं यार. Sorry.
Thank you, Dr. Manocha, for such
Okay,
an
sir. Thank you very much.
extensive, elaborative, and descriptive shoulder examination. Now, I will request Dr. Rehan to ask the questions, and the topic is open for discussion with the various panelists, and all the participants can ask actively either on chat or through WhatsApp. Dr. Rehan, please.
Yeah. So, am I audible to Dr. Manocha and everyone?
Yes, sir.
Yes, you are.
Yeah, so Dr. Manocha, congratulations for a very wonderful lecture and a very elaborative discussion on the various tests for the shoulder. I think the shoulder examination is always a difficult one. I think what I'm going to do is I'm going to take up the questions which have come up on the chat first, and then maybe I have an open house with all the participants, right?
Yes.
So one question is from Dr. Maninder and also from most of the delegates about the movements, right? So you talked of true movements of the shoulder in the plane of the scapula, and then some other movements. Can you just elaborate, because probably that point was not clear to most of the people who were there on the Zoom meeting.
Okay, I go back to my presentation again then. Just a minute.
If you can just tell us that from a PG's exam point of view, if they are told to demonstrate the movements at the shoulder, what are the important movements they should demonstrate? Probably that will answer the query.
Okay. Now, movements, all movements you are maybe asked to demonstrate: abduction, adduction, hyperabduction, hyperadduction, hyperflexion, flexion. These are the common movements you'll be asked. But what you will be, and you will be able to do them, considering that you have been doing that always in the hip also. And you take a reference from another ball and socket joint, which is the hip, with the only difference that the shoulder has hyper components also beyond the 90 degrees abduction range, which is present in the shoulder. Now, the confusion comes in the horizontal part and the forward abduction part. That is because the plane of the scapula is not exactly the plane of the body. The plane of the scapula is around 25 degrees angulated forward towards the plane of the body. If I had been making a live thing, that I would have shown you my own movement in the true plane of the scapula and in the plane of the body. But I'll try to explain it with the words only. So that if you are asked to show the abduction in the plane of the scapula, then your adduction and abduction arc starts in 15 degrees front of the plane of the body. 15 to 20 degrees front of the plane of the body. And likewise, if your flexion extension plane, true plane is asked, this is in 15 to 20 degrees in the area in the front of the body, and 15 to 20 backwardly directed out of the body. Out of the body will be extension arc, and the forward and front will be the flexion arc. Lateral 15 degree forward of your body in the up and down will be your abduction arc. That is what is the true plane. And the normal plane, if you are asked, did I make myself?
I think what you are. Yeah. I think I need to get Maninder over here in the discussion if Maninder is there. So
sure,
because this question.
Yeah, sure. I think
Maninder, does it answer?
No, I think
does it answer your question?
I was clear with this part actually about the normal plane of movements in the scapular plane of movements and the anatomical plane of movement. But if you also said something about the horizontal and the vertical movements, there's something else you mentioned which I didn't actually catch very at that time, and I just wanted to ask you what.
So what is the horizontal part? Okay.
Yeah.
No,
okay, Dr. Manocha, just hold on.
Yes,
I think what Maninder is saying, I think for the postgraduates, if they are asked to demonstrate movements at the shoulder, they have to demonstrate movements in the plane of the scapula. Is that the consensus, and is that what you are trying to say, right?
Not really. Actually, I always like to ask the movements of the shoulder in the plane of the scapula, but only recently I attended a DNB exam with somebody, so they wanted the things to be demonstrated in the plane of the body, in the anatomical plane. So what is important for
so
the
just hold on, sir. Just hold on, sir. So I think Maninder and Dr. Manocha, what Dr. Manocha is trying to say, if a postgraduate is asked to demonstrate movements at the shoulder, in the first instance, he should try to demonstrate in the plane of the scapula, and I think that is good enough. However, if the examiner goes forward and asks something more than that, then what Dr. Manocha is talking of in the next part will be important, right? So Dr. Manocha, now you continue. So we know what are movements in the plane of the scapula, which are to be demonstrated by the postgraduates. Now talk of the other thing which Maninder is asking.
Yeah, basically, now if you talk about the normal abduction, adduction, and a flexion extension arc, they are not occurring in a horizontal plane. The shoulder, because of its extreme mobility, has a movement happening in the horizontal plane also, starting from say level with the other shoulder to the extreme of this shoulder. So that is in a horizontal range of motion. So what is this motion? Is this abduction, adduction, or this is flexion extension? Because mind you that this movement is occurring partly in the flexion extension arc and partly in the abduction, adduction arc. So to make this movement distinct, we have added this name. We have given this a different name: a horizontal adduction and a horizontal abduction, or a horizontal flexion or a horizontal extension. That is what is the word. This horizontal has been added just to make the communication between the two people clear. Is that point clear?
Yeah. Maninder, anything? Maninder, yeah.
Just what I understand, that
Dr. Sharad, I'm going to come to you. Dr. Sharad, just hold on. I'm going to come to you. Maninder, are you okay with the answer that you've got?
I think so. It's you mean that the horizontal plane of movements is a combination of movements of the the abduction adduction plane and the flexion extension plane.
Yeah, exactly. So, that is what my whole point is.
Okay. Yeah, that's fine. That's what I want to clarify.
Thank you, Maninder. Dr. Sharad, can I have the question from you now?
Right. So, Dr. Manocha, as I understand, you mean the horizontal movements are seen when the shoulder is at 90 degrees of abduction. Am I right?
Yes, sir.
Right.
The plane is there, sir.
The plane is that. So there can be many planes then. It can be 80 degrees also. It can be 120 degrees also. So there can be so many planes of movement in which you can see the.
So anything above 90 degrees, you are already talking of hyperabduction. So that is defined.
Right. So
so you are already talking about hyperabduction.
So why do you want to particularly talk about a movement at 90 degrees of abduction? What's the importance of that?
Because that is a very important movement for day-to-day activities. Let me tell you, most of the movements are combination of flexion adduction and a combination of extension abduction. And our most applicable and most useful arc is this 90 degrees abduction. So that's the reason this requires a separate mention in the whole scheme of time. It's not my doing, actually. This is how it is described in the examiner, in the books as well.
Okay, Dr. Sharad, so that answers your question, right?
Right.
So you can mute yourself. Dr. Samarjit, do you have a question? You raised your hand at one point of time.
Yeah, I just wanted that Dr. Manocha can demonstrate the movements in front of the video. You can be a little away from it and everybody will understand it much better. That is what I wanted. In a normal class, we would have done that. If you stand a little away, we are able to see you. We will be able to appreciate you much better. And probably that will clear all the things.
I actually tried doing that. I made a video with my this web camera. The whole thing was looking completely bad. So
okay, fine.
Unless you have me in a three-dimensional view, you cannot really be appreciated.
Fine.
Okay. So I think what Dr. Manocha is saying, that is not possible. Dr. Samarjit, you can mute yourself. Any other questions from the panelists or from the students about movements at the shoulder joint? Otherwise, we move on to the next one, right?
Some audience want to know that whenever they have been asked to demonstrate the movement, either it should be first the anatomical movement or the true movement of the shoulder.
See, that is a point. I have never been. See, I started with this saying, I want all my DNB students whenever asked to demonstrate the movement of the shoulder, to demonstrate the movement in the plane of scapula. But recently only I came in contact with an examiner who wants, unless specified, to see the movement demonstrated in the anatomical plane. He then again asked, what are then the movement in the plane of the scapula? So it is not they made they mention any movement, but they have to specify and qualify what
I think
movement they are
Vineet,
telling.
Dr. Vineet and Dr. Manocha, I think there is one single take-home message. If the student is asked to demonstrate movements at the shoulder, he would say, "I am going to demonstrate movement of the shoulder in the plane of the scapula," and
Yes.
those are good enough.
Yes.
If the examiner asks him further, and then he can demonstrate in the other. I think that is the single take-home message that we have from the movements point of view, right?
Yes, sir.
Let us move on to measurements now. My question to you is, sir, what is the importance of measurement in a shoulder case, and when will you advocate it? And in the meanwhile, I would want all the other panelists to think of any questions if they have on measurements, and then we are going to move on to the next thing.
Yeah, measurement, like anywhere, they will be your base reference to prognosticate and to see the benefit of whatsoever treatment or whatsoever the intervention you might have achieved. And then it is very important in shoulder to make a distinction between glenohumeral movements, their measurement, and the total movement, because that is what really decides whether the problem sits in the glenohumeral joint or in the shoulder girdle as a whole. So you have to measure these movements, and otherwise also because that just completes the range, whole examination. We have been in a habit of asking them to tell what the movement is, and then we ask them dikhao. So that's how they aren't supposed to know what measurement they are expected to show.
Okay. Any other questions do we have on measurements, or then we move on to the special tests? Vineet, anything you want to add about measurements, or I want to get Dr. Hitesh also here.
Yeah. We just wanted to know what is the importance of measurement, not only the movement, so measurement of the movement. It is basically the measurement of the shoulder joint as such also.
Truly speaking, I have never measured that length, apparent length, or a true length of upper limb. I really never measured Apple's scratch test lengths. I don't think they are really of any much clinical importance. But my examiner might ask you if you were to say there is a growth retardation in a child because of some epiphyseal arrest in the proximal humerus, and that short humerus is short, then how do you say that that is short? Then that is where they are supposed to be measuring. That is how they are supposed to be qualifying their statement, and that is how they are supposed to be doing it.
So
Dr. Manocha, can you elaborate on the measurements you showed in a slide on scapular dyskinesis?
Measurement, okay. Let me, can I share my present? Okay. Now what you are supposed to do is that you are supposed to draw the vertebral spines, okay, in the, from say, the over the span of the scapula. And then you're supposed to draw that there will be a straight line which is representing the midline, and then there will be a line which represents the medial border of the scapula. At 0-degree adduction, you are supposed to measure the distance on the medial border of the scapula from the midline on the right side, on the left side. Then you're supposed to go at 45-degree abduction, and then you again measure from the same point at right side and then left side. And then again at 90 degrees, right side and left side. A difference in these measurements compared to the other side, on the affected side, indicates that your scapula is not normal anatomical position, and the clinical symptomatology and sign may have been affected because of the bad initial position of the scapula, and therefore patient might be having scapular dyskinesis.
Okay.
Thank you.
I think, Dr. Manocha, we will move on to the measurements thing, and we come on to the special tests now. Those who want to ask a question will just unmute themselves. Other, please remain mute so that we know who is asking and who is this thing. One question which have come up from the students, and I think which is very relevant. If you look at the DNB exam pattern and also the PG exam, the shoulder case will usually be a short case for the postgraduates. And for the DNB, it will be a 50 marks case which they have to do in 30 minutes. it is not possible for them to do the whole battery of tests which you have very nicely elaborated. So basically what they are asking is, sir, what are the important tests which they should not miss out and do them quickly?
Yes.
Just if you want to, will that be based on the history, a focused history, and then a specific set of tests, or will it be a battery of tests that you will advise in all patients?
No. I told you that there are three kind of complaints: pain, instability, and a weakness. Your test should be guided by what kind of the chief complaint is present. But in any case, these tests are supposed to be known to the examiner, known to the examinee, so that if the examiner wants to ask, okay, which test, how is this done, so then he should be able to know. But coming back to your saying that the shoulder is a short case in a DNB exam, let me point out that there is nothing like now short case in DNB. All cases carry
all 50
equal,
marks case, right?
all cases carry equal weightage, and examinee can be caught on any case. Shoulder cases are usually not the part of the examination, but they are going to become more and more part of it.
Right, sir. So just focusing on what you have said and just taking that discussion forward, you said based on the focused history, there will be either pain, there will be either instability, or there will be weakness. We understand there will be gray areas in between.
Yes.
So if there is a patient who comes with pain, what are the tests that you will say you need to do? If he comes with instability, what are the important tests that need to be done? And in case of weakness, just very briefly, so that they know ki acha ye mere ko miss nahi karna hai. These are the ones which can have a backseat.
A patient with a pain in the shoulder, of course, I am not including the acute conditions due to trauma or dislocation. So we're talking about chronic condition. So the tests of impingement are important for pain. The range of movements and the stiffness, they are important for a pain. And general, I guess that's the only thing which we do in pain. Whenever there is a pain, you need to check whether the movements are painful or movements are pain-free, whether the active range is good or passive range is good, and finally, if the active range is good, their impingement test. That's how what you do in a pain.
Right. And for instability?
Instability, all the three components of the test should be done: apprehension, augmented apprehension, and relocation. There are three components of all instability. So if he has an anterior instability, actually you're supposed to test for all instabilities, front, back, and inferior, whenever a patient of instability comes. But an apprehension test, an augmentation of the apprehension test, and a relocation and release test for an instability are the basic minimum and necessary.
Right. And I think for the weakness, you have already talked of the supraspinatus, the infraspinatus, the teres minor, and the subscapularis.
The rotator. The rotator.
So, yeah. So I think the clear take-home message for all of the PGs who are very confused about the large number of tests you have for the shoulder is that you need to take a focused history, identify whether the patient's main complaint is pain, whether it is instability, or whether it is weakness. And based on that, you're going to do the special test, and most of the times you're going to get to a diagnosis. Yes. Is there, from the panelist, does anyone want to add anything here? Those can just unmute themselves and can start saying whatever they want, and then maybe move ahead.
Dr. Rehan, can I put a comment?
Yourself.
Yeah, definitely.
Unmute yourself.
Yeah, I think I have, yeah.
Yeah, Samir, go ahead.
Yeah. See, I think it's very clear. You start with the history, which is very relevant. You start with the age. I think Dr. Manocha very rightly summarized everything. You start with the age. A person coming at 60 has the chances of having rotator cuff tear more often, and arthritis and so on, rather than instability and rather than impingement. So the moment a person walks in, I mean, of course, this is what I'm saying is, of course, for all the postgraduates and younger surgeons who are listening. So the moment a person comes and says, I've got pain, so you immediately categorize he is around elderly person and he would be having these arthritis or cuff tears, etc. A younger person will have instability and impingement. So this is one. So you categorize it immediately. And then next comes, what are the tests I can do to come to a firm diagnosis from a provisional diagnosis? How to come to a firm diagnosis? And you go on to all these Hawkins tests and the Neer's test, and you categorize accordingly. So if you have a quick kind of a chart in your mind about the age, about the presentation, and then the test that you have, it won't take more than 5 to 10 minutes to come to a complete diagnosis further, and then you go further for radiological and so on. Am I right, sir?
Yeah.
Dr. Manocha?
Yeah, I agree with Samir. Most of the time we sitting in the OPD or never take more than 2 tests ever for any shoulder case. We listen to his chief complaints and we already know which test to conduct, and we arrive at a diagnosis quickly what needs to be done.
So I think So I think the most important message that Dr. Manocha at this moment is trying to give is a focused history is very important. Once you have taken a focused history, you need to divide your pathologies into whether it is pain, whether it is instability, or whether it is weakness, and then do a limited number of tests, and that are going to help you. And one clear message I think which need to go to all the audience is that doing over investigating the patient in the forms of X-rays and MRIs and ultrasound probably is just additive. They don't help you in a diagnosis unless and until you have taken a good history and clinical examination. Is it right, Dr. Manocha?
Yes, sir. Yes, sir.
So I think if we don't have any more questions, we can have an open house sort of thing where most of the panelists can contribute, and then if Vineet agrees, we can bring this whole thing to a conclusion. Vineet, I think I need to hand it over.
Yeah. I think it can be open to all the panelists. And first of all, I myself want to know, ask from the Dr. Manocha itself. For the Dr. Manocha, in OPD, we are getting very frequent patients of frozen shoulder, which have been labeled as a frozen shoulder, though it is periarticular arthritis and all that. So what do you say about all these things? How to diagnose it, and what is the exactly few basic tests how to perform this so that it can be useful in the OPD?
Frozen shoulder is actually a misnomer. So there is nothing like a frozen shoulder. So the patient may have actually a restriction of movement. He may not be actively able to do it, or when you try to do it, once he is not able to actively do it, you try to do it, then you are also not able to do it. So if both active as well as the passive are gone, the patient is likely to have a stiff shoulder. So to say that your pathological diagnosis will be a periarthritis. Now, patient is not able to actively do it, but you can passively do it. Then that is to be characterized as a weakness, because that is somehow coming from his rotator cuff. Now, the patient is able to do both active, and you are also able to do a passive, but the patient complains of pain. Now comes the test for impingement. So the patient carries up, and then you conduct the impingement. So this is all are called basically a frozen shoulder. So you must differentiate that those coming with the frozen shoulder will be the number one will be both active and passive gone. 2, active gone but passive full. 3, both active and passive are full, but the active, when he does, he has a painful arc. So for a painful arc, you conduct the impingement test and you come to the diagnosis of an impingement, right? These are the things which are called as frozen shoulder so commonly, but they're very easy to differentiate from each other.
Dr. Harmesh,
Dr. Manocha.
Dr. Harmesh, go ahead.
Yeah, Dr. Manocha, can you hear me?
Yes, sir, I can hear you.
Okay, so if there is a pain, there is something called pain inhibition.
Yeah.
Pain inhibited, you can say power of the muscles. So in case the patient is having pain, you can't actually demonstrate the muscle strength in that patient.
Yes, sir.
So what about the infections, the tubercular pathology and things like that? Where does it come into the picture in the case of shoulders?
So infection are to be worked up in shoulder, much the similar way they will be worked up everywhere. You have to look for 5 signs of inflammation. You have to look for the history. You will get some sort of sinuses, some collections. That's how you differentiate infection here also. Of course, see, my tests were basically for this shoulder was basically focused on making a distinction between these 3 complaints: the pain, instability, and weakness, which is inherent to the pathologies of the shoulder. Now, infection can happen anywhere, trauma can happen anywhere. Their presentation will be like everywhere else.
Yeah, I think just for the postgraduates, there is something like Keri Sikka of the shoulder. because the tuberculosis of the shoulder presents in two different ways. It can present like a frozen shoulder where it's a dry sort of a lesion, and the movements at the shoulder will be lost. And then you can have a wet sort of a lesion where the patient will present with classical sort of osteoarticular tuberculosis. So I think that is one message which the students must know. If they have a shoulder where there is gross wasting of muscles and the movements are completely lost, and it is a relatively young patient, think of tuberculosis of this of the shoulder, and that is a Keri Sikka sort of presentation. So it's called dry shoulder, right?
Examinees will never be asked to make a diagnosis of whether the tuberculosis is present or not.
Right.
If the patient has a frozen shoulder with a complete loss of active as well as passive range of motion, they are supposed to make their first diagnosis in the absence of active signs of inflammation or sinuses, etc., to make the diagnosis of periarthritis only. Then they can make the differentials. Then they can make the differential of, say, primary osteoarthritis or secondary osteoarthritis or even a Keri Sikka. So that's how you should go about it.
I think because more. Definitely.
Dr. Manocha is a very nice presentation, right?
Right,
so
thank you.
This is a small comment, right? PG is given short case on shoulder. Rotator cuff is a diagnosis, right? So the examiner asked him to examine and tell me one or two tests, right? There are four main muscles, right? Supraspinatus, infraspinatus, and teres major. And what two tests you will advise they have to perform to confirm or to come to some diagnosis for in short case?
So they have to,
among all these four muscles, which two muscles or which two tests you will advise to go for it?
Let's see, there are four muscles and then the four tests are necessary. At least four tests are necessary. They have to do an empty can test for supraspinatus. They have to do a Gerber lift off test for subscapularis, and they have to do a abduction extension, external rotation lag sign for their external rotators.
Yeah, I think most of the queries are now answered. I would want Dr. Sharad, just get Dr. Sharad Agarwal so that Dr. Sharad Agarwal can conclude this this thing, webinar, and then.
Manocha, very exhaustive talk you have given us. One point I want to raise is about impingement and impingement syndrome.
Yes,
I think this is one of the commonest conditions which we see in our day-to-day practice, right? And patients, they come with varied kind of presentations. I mean, they won't get a classical. And if we read the literature, there are a variety of impingements also, extrinsic, intrinsic, subcoracoid. Do you, in the history or examination, try to further, locate, to find out which kind of impingement it is and what are the common features we should expect in a case of impingement syndrome?
See, you are very right that impingement can be due to intrinsic causes and extrinsic causes. To begin with, in one of my slides, I just cut off extrinsic and we are not talking of extrinsic causes. See, what test of impingement I mentioned are tests for a subdeltoid impingement. Now, subdeltoid impingement intrinsic to the shoulder. That means because of some inflammation or some swelling, the subdeltoid space is decreased. Those impingement tests are only for detecting that thing. Now, impingement can happen because just to the bad position of the scapula will tend to decrease your subdeltoid space, and then you're supposed to make a diagnosis of scapular dyskinesis. There can be a gym people who are making a lot of push-ups, etc. They may have their scapula high riding. Now, high riding scapula will make the scapula protracted forwards. That also reduces your subdeltoid space. These people will have pains of impingement. Now, my jaw impingement syndrome has at least 30 causes, and it would be a full lecture to discuss each of those causes separately. What test I have described is only and only causes of impingement, subdeltoid impingement, with a reason intrinsic to the shoulder.
Yeah.
Dr. Manocha, what would you expect in history when the patient comes in such situations when you expecting subdeltoid impingement? What would be there in the history which will point towards that it is likely to be a subdeltoid impingement?
Subdeltoid impingement is patient has a good position of the scapula, has a good range of motion, but has a painful arc, and your impingement tests are positive.
Yeah.
Specifically,
I think we are getting, Dr. Sharad, sorry to interrupt, but I think we are getting into the domain of shoulder surgeons. This is a very basic, this thing for the postgraduates, for them to understand how to present a shoulder case. So probably you can have a personal discussion with Dr. Manocha on that. And we have had almost 1.5 hours of, I think, good discussion. If with your permission, we can bring this to an end, and on behalf of DOA, we would thank Dr. Manocha, and I would like Vineet to take over from here, right? Who's the main force behind organizing these seminars? Vineet.
Yeah, thank you, Rehan. Thank you very much for moderating this session. And my special thanks to Dr. Manocha, who has taken intensive efforts to, even though he was quite busy in his day-to-day activity from the hospital after doing surgery and all that, he could spare some time for this presentation for the sake of PGs. I must thank on behalf of DOA to him. And I request Dr. Sharad to have a few words for him, and then we can wrap up the session.
Thank you, Dr.
Thanks, Vineet. Well, my sincere thanks to Dr. Manocha for giving such an exhaustive talk on a subject which is quite confusing. I'm sure it confused many senior colleagues of us, but by discussion, I'm sure we are able to learn more and more, and we'll keep learning like that. Right. Thanks to Vineet, Dr. Rehan for organizing it so well, Dr. Maninder for getting such good support, my other EC colleagues, and all the delegates who have joined us for this webinar in this afternoon when it's a time for SISTA, and made it a success. Thank you.
Thank you, sir. Thank you, everybody.
Thank you, Dr. Manocha.
Thank you, sir.
Wonderful
you,
presentation.
Thank you,
Thanks, everyone.
Thank you very much. Thank you.
Thank you.
Bye.
Good night.
Bye. Good night.
Everybody.